So, hi everyone. I'm Dr. Ross from Paris, France. This lecture is on the EU-TIRADS. We will be speaking of risk stratification of thyroid nodules and indications for FNA. Welcome to everyone. So, in 2017, the European Thyroid Association published guidelines on ultrasound malignancy risk stratification of thyroid nodules in adults, the so-called EU-TIRADS. It was a pleasure to share this work with all this group, and Cosimo Durante and Rose New are part also of this ETA basic US course, of course. So the ETA thyroid guidelines is an integrated system, which means there is a standardized terminology, a standardized report, a score for US risk stratification, of course, and some management recommendations. This is the illustrated lexicon. The aim was to standardize terminology for US reporting, so as to increase inter-observer agreement. I will be showing you numerous examples of this lexicon during the lecture. Second, there is a standardized report, which aims also to increase inter-observer description agreement. And I want to insist on the fact that in the results section, you have to describe the ecogenicity and vascularity of the gland, because in turn, this will modify your sensitivity for the detection of thyroid cancer, and it can also produce some images of pseudonodules. Regarding the nodules, you will describe their location, their size in free diameters and volume, their US characteristics, of course, and assess their EU-TIRADS score. You can number and map them out on this map that is easily downloadable on the website of the European Thyroid Journal, and you see that you can put them here. You can even color them so as to exchange really easily with your fellows and with the patient. In the conclusion section, you will assess the category of the main nodules. There is no such thing as a EU-TIRADS score of an entire US report. It is specific to one or several nodules, and you can make some management recommendations. So the EU-TIRADS score, of course, is the core of the system. It ranges from 1 to 5, with an increasing risk of malignancy. 1 is for no significant nodule, 2 is for benign, 3 is for low risk, 4 is for intermediate risk, and 5 is for high risk. On the right column, you have the malignancy risk we deduced from the literature of the past 15 years when we wrote out the guidelines. For score 2, it is practically 0. For score 3, it is between 2 and 4%. For score 4, from 6 to 17%, and for score 5, from 26 to 87%. So as this was not exactly a speculation, but has not been submitted to any trial, several trials were issued after the publication of the guidelines. This is one of them. Its quality is that it used histological diagnosis as gold standard, and it was a multi-center study also in 3 different countries. And the observed cancer risk at the bottom right of the slide, you see, is in the upper range of what was predicted during writing the guidelines. So it is true. Why is it in the upper range? Because it is against histology and not against cytology. And you can see on the upper part of the slide that the sensitivity of the EU-TIRADS was quite good, 93%, and its negative predictive value was also very high, 97%. So how do you score a nodule? You just have to look for features of high suspicion, and if there is at least one of them, you will score the nodule, as EU-TIRADS 5, that is to say at high risk of malignancy. As features of high suspicion, there are 4 of them: a taller than Y shape, irregular margins, microcalcifications, and marked hypoechogenicity. So these EU-TIRADS 5 nodules represent 5% of all nodules. So why is there such a wide range of malignancy risk in that category? There are several reasons, but one of them is that the risk increases with the number of features of suspicion, like it has been shown in many publications like this one. And you see that with one feature of high suspicion, you're like close to, let's say 25, 30% risk of malignancy most of the time. And when you increase the number of features of high suspicion, you get close to 100%. So let me show you the features of high suspicion. Some examples. So this is a taller than Y shape. Taller than Y shape means that in the transverse plane here, the nodule is thicker than it is wide. It can also be taller here, which means thicker than long in the longitudinal plane. And the value of these two features, taller than long and taller than wide, is practically the same. Another example, in the right part of the slide, you see here in the transverse plane, the nodule is thicker here, which means taller than it is wide. And in the longitudinal plane, the taller than long, it's thicker than it is long, taller than it is long. So this is a feature of high suspicion. Second feature of high suspicion, irregular margins. Here you have 2 subcategories. The speculated margins are at the highest risk of category compared to the second subcategory. So speculated margins mean sharp angles, and there should be at least 3 of them to make this sign positive, to consider that it is present, to raise the specificity of this sign, of this feature. And now you see the speculated margins here, the sharp angles, there again. And the second subcategory, which are lobulated margins, means small rounded protrusions, like the one you see here. There again, you should see at least 3 lobulations, and it is a little less specific than irregular margins. Microcalcification, so here the definitions should be very strict to assure some specificity, because on the contrary, as there are many hyperechoic foci, these microcalcifications are part of a group of hyperechoic foci. If you're not strict with the definition, you will describe them in an inappropriate way too frequently, and you will make false positive cases. So the definition is that they measure no more than 1 millimeter taken individually. They are located, and this is very important, in the solid part of the nodule. They do not generate comet tail artifacts, at least measuring more than 0.5 millimeter, and they are not associated with microcystic cavities. Their number also should be taken into account, because if you have less than, let's say, 4 or 5 hyperechoic foci, very probably they are not microcalcifications. And their grouping is also very important. So I put here some obvious cases, and I think you should consider them present only in that cases. There are other types of hyperechoic spots, as I was saying. So a very benign one, on the contrary, is when these hyperechoic foci are located in the cystic part of a nodule. They measure between 0.5 and a few millimeters, and they generate a cometoidal artifact like the ones you can see here. The special and more frequent case even is the one of microcystic cavities. Now here, if you turn the compound off, you will see these microcystic cavities and these rather linear small hyperechoic foci in it, and you will even see them better if you enlarge the image, if you zoom. So let me show you another example, as this is very, very frequent and in favor of benignity. You see here, I have the compound on, and you cannot differentiate this small hyperechoic foci from true microcalcifications. Now, if you turn the compound off on your US machine, then you will see much better the hyperechoic the microcystic cavities, and you will make the good diagnosis. Fourth feature of high suspicion is marked hypoechogenicity. Marked means, of course, more hypoechoic than the surrounding thyroid parenchyma, but also more hypoechoic than the surrounding strap muscles. Even if a nodule is partly markedly hypoechoic, sorry, it is considered as marked hypoechogenicity. So beware of two false positive cases. The first one are shrinking cysts. You see this nodule on March 2016. It is taller than it is wide. It has marked hypoechogenicity, but curiously, it is strictly avascular with a surrounding halo. And if you go back in time, you see that the nodule was bigger, rather isoechoic, and even before this, 3 years before these pictures, you see that it was mainly cystic. Shrinking cysts give, after sometimes, these images, which can be misleading. Other cause of false positive cases, subacute thyroiditis. You see that it can really lead to marked hypoechogenicity, irregular margins, taller than wide, but you have really to speak with the patient. And if this causes pain, if this has not really regular margins, but difficult to see margins, blurred ones, then you will be able to evoke the diagnosis of subacute thyroiditis. Now, the second cause of this wide range of malignancy in EU-TIRADS 4 nodules and even in EU-TIRADS, moreover in more EU-TIRADS 5 and EU-TIRADS 4 nodules, are the specific aspect of thyroid cancers. What I mean is, how do thyroid cancers generally look like? Usually they look like a nodule, not a mass, or not only microcalcifications. Usually a thyroid cancer is solid, and usually it is hypoechoic. And it is even solid and hypoechoic in 74% of all carcinomas. So this has a lot of impact on the positive predictive value of high-risk features. Let me show you this example. You see these two nodules are taller than wide. Here, taller than wide. But this one is mildly hypoechoic, and this one is isoechoic. So this one has a lot more risk of being a carcinoma than this one, because carcinomas are more frequently hypoechoic than isoechoic. In the same way, it has been shown in 2021 that for hyperechoic foci, the positive predictive value is a lot smaller in nodules of mixed composition than in solid ones. Now, let us carry on with the EU-TIRADS score. If you have none of these four features of high suspicion, the system is very simple because it relies only on the echogenicity of the solid part of the nodule. That is to say, if it is mildly hypoechoic, even partly, then the nodule is at intermediate risk of malignancy. EU-TIRADS 4 does represent around 1/4 of all thyroid nodules. If it is entirely isoechoic or hyperechoic, it is at low risk of malignancy. EU-TIRADS 3, this represents 63% of all nodules. And if it is anechoic or entirely spongiform, then it is benign. EU-TIRADS 2, and this represents 5% of all nodules, like the EU-TIRADS 5 do. So that is to say that EU-TIRADS 2, 3, and 4 nodules, of course, have oval shape. Otherwise, they would be EU-TIRADS 5, and they have regular margins, of course. Otherwise, they would be also EU-TIRADS 5. So this is an example of a EU-TIRADS 4 nodule. You see that it is mildly hypoechoic, not more than the strap muscles, but more hypoechoic than the surrounding thyroid parenchyma. This one is isoechoic, so therefore it's the EU-TIRADS 3. EU-TIRADS 4 correspond to two subcategories. Simple cysts, that means that there is no solid part, especially an eccentric solid part. No one, no. And the second subcategory is EU-TIRADS 2. Of EU-TIRADS 2 are spongiform nodules, of which definition should be very strict also. This means numerous tiny microcystic cavities occupying at least 75% of the whole nodule, separated by isoechoic tiny septa. So let me show you some example. I hope the movie works. It does. So you can analyze when you look at a nodule, first its shape, second its borders, and then dive into the nodule and analyze its echogenicity and if there are hypoechoic foci. So this one you see is taller than it is wide. It has irregular margins, numerous hypoechoic foci, and it is mildly hypoechoic. So this is an example of EU-TIRADS 5 nodule. Second example, this is an oval nodule, oval shape, and it is with regular margins. Here it is solid and it is mildly hypoechoic, no hyperechoic foci. So this is a EU-TIRADS 4 nodule. Third example, this nodule has oval shape, regular margins, it is mainly cystic, and here you have an eccentric solid part, which is isoechoic, therefore it is a EU-TIRADS 3 nodule, and do not confuse this hyperechoic spot with a microcalcification as you have the microcystic cavities. Another example, which is very important, of EU-TIRADS 3, not only nodule, but nodules. You see these are numerous coalescent nodules. This is one, this is one, this is one. So in case these nodules are coalescent and isoechoic, it is scored EU-TIRADS 3, and it is very likely to be benign. Now, what I want to call your attention on is to differentiate mixed composition and spongiform pattern. Is this a spongiform nodule? No, because the microcystic cavities are too large and they do not occupy more than 50 to 75% of the whole nodule. The septors, the solid part is too thick. So this is only a nodule of mixed composition. This is a spongiform nodule. You see again numerous microcystic cavities occupying at least 75% of the whole nodule. So in real life, we're really dealing with multinodular thyroid disease rather than with single nodules. And here the EU-TIRADS 5 is very useful. Here, what you have to do is start by looking for nodules of at high risk, EU-TIRADS 5, and then you will describe them whatever their size is. Then you look for intermediate risk nodules, EU-TIRADS 4, and you describe them if they measure more than 5 millimeters. If you do so, and there are no such nodules, then the risk of malignancy is below 5%. And then you will look for low-risk nodules, EU-TIRADS 3 and 2, and you can describe them if they measure more than 10 millimeters. So this will help you reducing the number of nodules that you will describe. You will gain time, you will gain efficacy, you will be more relevant, and when you do so, you will describe a mean number of 3 to 4 nodules only. Now, if you have understood what we have done to score a nodule, we have used only what we call cardinal features: shape, margins, echogenicity, microcalcifications. Then this will in turn give you the score of a nodule. You will look for suspect lymph nodes, and you will decide if an FNA is indicated. But of course, there are other US features that we can use, and these features, they will modulate, of course, the risk of malignancy, but they won't modify the EU-TIRADS score. So they will help you only to adjust the indication for FNA. So these accessory US features are composition, halo, macrocalcifications, colloidal features, extrathyroidal extension, vascularity, and stiffness, depending on the fact that they are present or absent. This will in turn modulate the risk of malignancy, but there again, not modify the EU-TIRADS score. So let me show you some examples. On the top of the screen, you have nodules of mixed composition, and they, in green, lower the risk of malignancy. These nodules at the bottom of the screen are only solid, and this composition only solid in red increases the risk of malignancy. The halo, if it is present and thin, it reduces the risk of malignancy, and it eliminates pseudonodules linked to thyroiditis. On the contrary, if the halo is absent and it is a true nodule, or it is thick here, like this one, then it increases the risk of malignancy. Macrocalcifications, two subtypes. If they are central, they do not alter the risk of malignancy. And if they are peripheral and disrupted, on the contrary, the risk is increased. Extrathyroidal extension, no capsular contact, practically no risk of microscopic or macroscopic thyroid extension. And on the contrary, on these images, if you see the nodule invading the strap muscles, so this is very suspect of macroscopic extrathyroidal extension. Vascularity plays no significant role in US risk stratification, but you can describe it as peripheral here, as a mixed location, central here, and peripheral, but of intermediate importance, or of course, mixed peripheral and central and intense. Elastography, stiffness, where you see with strain elastography a nodule of low stiffness. Here, the same with Sherway elastography. This is normal or low stiffness. Here you can take a cutoff of, let's say, 25 kilopascals to separate low from high stiffness. And these are examples of high stiffness nodules. Here with strain elastography, and here with Sherway. What you can memorize on elastography is that it has not been retained by most US risk stratification systems. It still has some a good sensitivity and specificity for the detection, of carcinomas, but the inter-observer reproducibility is quite low. So if you are really a beginner in US thyroid imaging, it can help you because it can help you detect papillary carcinomas, which can be of high stiffness, but it has no value for follicular carcinomas or for the follicular variant of papillary carcinomas, which are also sometimes difficult to detect with classic USB modes. So let's turn now to the fourth part of the ETA guidelines, which are management recommendations. They depend on size thresholds and, of course, the score of a nodule. So under 10 millimeters, you will always perform an FNA if there is a cervical lymph node, suspect one, of course, I mean, and then you will perform the FNA of the lymph node with a washout TG and the FNAB of a suspect nodule or more suspect nodules. I advise you to do so with a suspicion of macroscopic extrathyroidal extension. And under 10 millimeters, the FNA can be discussed if a nodule is EU-TIRADS 5 and located near the inferior laryngeal nerve or trachea, if the age, of course, is under 40 and according to the patient's wish. And there is a special case of active surveillance of EU-TIRADS 5 nodules that increases in size. Second, above 10 millimeters, you will perform the FNA for all EU-TIRADS 5 nodules. Above 15 millimeters, you will add EU-TIRADS 4. And then above 20 millimeters, you will add all EU-TIRADS 3 nodules. If the nodules are grouped coalescent, as I showed you, you will perform the FNA only if the main nodule is above 20 millimeters individually, which is quite rare, and for EU-TIRADS 2, only for simple cysts if they are compressive. Now, you will also take into account to decide for the indication of FNA if there are clinical risk factors or biological one, of course. If there is a suspicion of medullary carcinoma with an increased calcitonin or RET mutation in MEN2 patients, multiple first-degree family history of thyroid cancer, history of neck irradiation during childhood, genetic factors, a PET scanner focal uptake and the nodule measures more than 10 millimeters, young patients, old patients, male sex, solitary nodule. So you will modulate your indications for FNA according to these factors. And by itself, size increase is not truly a factor of risk unless there is a rapid growth of the solid part. You will always assess the cervical lymph nodes. This remains mandatory. You will look for cystic spaces, thyroid-like tissue, microcalcifications, and anarchic vascularity, like we described in 2013 in the ETA guidelines, and you will only look for these features of high suspicion. When to follow up the nodule, I remind you that the growth rate, as showed by Cosimo Durante, on the average, it is 1 millimeter per year for the solid part. It is size dependent, so you can make your first US control at 12 months, and then depending on the size, if a nodule is quite huge, around 40 millimeters, I keep an annual follow-up, and if it is of small to medium size, I will follow the patient at 2 or 3 years after, and then each 4 to 5 years. So this is the last slide. The EU-TIRADS score, its main aim has been striving for simplicity so as to encourage people to use it and to use it easily. So look for features of high suspicion, FNA always if a nodule measures more than 10 millimeters, and discuss other options up to 10 millimeters. If there are no features of high suspicion, the system is dependent on the echogenicity of this solid part, and you will perform the FNA above 15 millimeters for EU-TIRADS 4, 20 for EU-TIRADS 3, no FNA for EU-TIRADS 2 unless they are compressive. Thank you for your attention.